Welcome back. We start with the last talk. I would like to invite Professor Tariq Salahuddin. He's the chairperson of Department of Neurosurgery, National Hospital, Lahore, Pakistan. He's the Dean and Chief of Postgraduate Medical Education and General Hospital, Lahore. His interests are in neuroendoscopic procedures, vascular neurosurgery, and brain tumors. I would like to invite him to give a talk on endoscopic endonasal transsphenoidal approach for anterior skull base.
Good afternoon, ladies and gentlemen. I think, sir, first of all, I would like to thank IPE and his team. It's extreme honor and privilege for me to come all the way to Biratnagar, myself and my colleagues, Hira and of course, Anila Darbar. We always find it very enlightening and see when IPE is there, and he's one of the most promising young neurosurgeons on the global scenario, and we're very proud of him. And the setup that you have shown, IPE, to us is very impressive. Not only that you have got the right tools, you are running a program, a teaching program, you're academic, and you're presenting your work all around the world. So I think to me and to my colleagues, that makes a lot of difference. It is not only that you're doing so many number of cases, you are doing a marvelous job and you're providing a service. Thank you very much. Actually, my main talk is tomorrow, but I think I am just stepping in for David. I think he couldn't make it. So it's about the endoscopic endonasal transsphenoidal approaches for the anterior skull base. Basically, I'm going to talk about the basic stuff, and then I'm going to take you to the higher levels of the base of skull. Some of that, I think Anila talked. Some of that, I think other speakers have spoken about that. Before I talk about the base of skull neuroendoscopy, I would like to know how many of you are doing, transsphenoidal endoscopic pituitary surgery or base of skull surgery. Okay, right. So I think we need to train more of our junior colleagues and younger colleagues, I would rather say, so that they should have the expertise to do this sort of this work. There is no rocket science about it, I will say. Evolution of endoscopic pituitary surgery, Guay is recognized as the first neurosurgeon to use the endoscopic transsphenoidal approach, although he abandoned the procedure because of the lack of adequate visualization. In the late 1970s, Apuzzo and co-workers, Boucher and Haff, reported the use of endoscopy as technical adjuvant in the microscopic resection of pituitary lesions with extracellular lesions as well. It is mandatory that when you're doing the base of skull surgery, that you must have an understanding, an absolute understanding of the neuroanatomy of the nose and also of the base of skull. The turbinate, sphenoid ostium, intersphenoid septum, optic nerve, opticokerotic recesses, tuberculum sali, clivus, planum, intercavernous sinuses, and of course, intracranial structures. This would be the main theme of my talk, and that, as you see, there are three areas that I would like to talk about and would like to concentrate, and that is the nasal anatomy and the base of the skull anatomy. And if you look at the vascular supply and the nerve supply, there are two arteries, anterior ethmoidal and the sphenopalatine artery. So I think these are the two which you have to keep, because we are always scared of bleeding whenever you're doing this procedure through the narrow cavities and taking, using a corridor which is very, very narrow. What is the problem with the microscope? For many years, every one of us, and even now, some of us find very, very comfortable with using the microscope. The light limitation as the field deepens, parallel lines, it works on in a tunnel vision. It cannot look into the corners. The advantage of endoscope as compared to the microscope is that this gives you a panoramic view. You'll have a look at this picture and you'll see as if there's a movie going on. Light sources closer to the target, direct access to the lesion, do not need a speculum. We don't have to have, and you just expand and you go through those structures and you'll find that you find enough space to maneuver your instruments there. The surgical steps, nasal, sphenoidal, cellar, supracellar, and of course the most important one is the reconstructing the base. Basic concept for the approach of for the nasal, the step, binostril approach, mononostril approach, 2 and 4 hand technique. What is a 2 hand technique? When the surgeon holds the endoscope, or when he has an assistant who holds. So it is a 2 assistant hands, and 2 the surgeon has got both hands free. So that is a 2 and 4 hand dealing with the turbinate, sphenoid ostium exposure, nasal septal flap, which is called the Haddad flap, posterior septectomy, and wide sphenoidectomy with posterior ethmoidectomy. Now, people talk of having a teamwork with an ENT colleague. Yes, it's very good if somebody is very, very familiar and is good with endoscopic nasal surgery. But unfortunately, when I started, I did not have somebody who was so expert in that. So I trained myself. I started my neuroendoscopy in 2000 with Professor Gabb, and then Schroeder, and then I went to Amin Kassam, and thereon I attended about 14, 15 neurosurgical workshop, endoscopic workshop, and over a period of 18 years, the learning curve kept on taking me to now extended radical base of skull surgery through the endoscope. The first step that you see here, the structure that you see here, is the inferior terminal, and this is the middle terminal. So that is the first step that you will be seeing when you use your endoscope. And next is to find the ostium, and that lies 2.5 centimeter medial to the medial terminal. And you will find, what I'll remove the patty, that you will see that you will be looking directly into the middle, terminal. I always take, this is the ostium of the sphenoid. I always take the middle terminal when I'm doing radical surgery. Sometime I can shave half of that, but most of the time, to have more space, I take medial terminal as a policy and as a rule. Basic concept for the approach of sphenoidal surgery: removal of intra and interseptal sphenoidal septi, removal of the mucosa, identification of these landmarks, extent of exposure. Anteriorly, it is the sphenoid to sella and planum. Lateral is the keratocavernous, bulges, optic nerves, and posterior ethmoid, and posteriorly, of course, it is the clivus. Now, the nasal septal flap, raising the flap, is also a technique. It's very important, and we should do it routinely once we are doing extended radical surgery. I would not do it when I'm doing a simple pituitary or cellular surgery, but if I'm doing a base of skull tumor surgery, I will always raise a septal flap so that that reinforces on top of my reconstruction, which I'll show you in detail. This is just the anatomy of the flap that we come as close as to the anterior aspect. You start, taking the flap here on the sphenopalatine. It is based, and this is another, diagrammatic picture. These are the most important tools which I have got lined up here. My drill, which is a Concord drill. It is specially for the transsphenoidal surgery. It is not an ordinary drill that you use it. It's a special Concord type of a drill. Then you have got, this is another type of a bipolar, I call it. This is, coagulation bipolar, and it coagulates, and at the same time, it can, do a little bit of cutting there. This is against, the bayonet type of the bipolars, again a bipolar, and this is the, Kassam, sort of a special bipolar, which when we have to use the intersphenoid sinuses, then supracellular area when we are dissecting the planum, and that is where it helps to coagulate that area. Again, this is of course the 0 degree, 30 degree. Sometime, very rarely, I would do a 70, but I feel comfortable with 30 degree and 0 degree endoscope. These endoscopes, also the channel, the dia of the channel matters when you're using pediatric or the adult type. Sometime I would take away the sheath so that it gives me extra couple of millimeter to enter into narrow, sort of corridors. What is a 1/2 rule? Remove the anterior wall of the sphenoid sinus widely, especially downward, before reaching the sella. The instrument will not be able to reach all the areas visible by the endoscope, and this is how you look at, 1/2 rule. You look at here, you are extending the sphenoid, The septum is intact. This I do when I'm only have to do, the cellar, surgery, like pituitary surgery. You just gently keep on nibbling, and these are the interseptal adhesions, septi, which you remove it. This is the sella here. This is the clini clivus here in this area. But you better be very careful when you do that, because if you're laterally removing these septa, they could be on the carotid bulbs. Once or sometime it can happen, then you nibble them, you nibble the carotid. So I think you've got to be a little careful here. I always use the drill when I'm taking away the base of the sella here. Sorry. Using a diamond mill, 2 to 3 millimeter, and once I've got a space there, then I use a special type of a cutter. So it does not damage the dura. So the equipment is very important, and how you use it, where is the scope you're keeping, so your vision is straight into the area where you're operating. How to cut the dura? Below downwards and from outside in, because the cavernous sinus is on the side. If you go your blade laterally, then you're going to damage that, and then you can curate that gently through that. Now, once you have done now, the advantage of endoscope is that it can take away the tumor. This is the normal pituitary. It can take away the tumor, which is even into the cleavages up there. And you'll see in a minute that I'll be bringing down more of the tumor from the suprasellar recesses. This only can happen with an endoscope. And this is when you go extracapsular. You are more aggressive, taking away the tumor. And now you can see the anterior you can see the vessels there as well. Anterior cerebrals, and in a minute you'll be able to see the complex A complex as well at this area. That's the one. Exposure of the cellar base, anterior planum drilling, opticocarotid bulb exposures, securing the coagulation of intracavernous sinus. That is again difficult, and I'll show you how one has to do that. Excision of suprasellar dura, intracranial structures, optic nerve, chiasma, internal carotid arteries, A1, A2, pituitary stalk, identification. This was a patient who had a small craniopharyngioma, T1 and T2, and this was removed. Now, after we have removed the now drilling the base, this is the planum area, and this is the the Kasam bipolar, which is the intercavernous sinus. This has to be coagulated well before you incise and go into the suprasellar in the region of the planum. But still, even coagulating well, still there's a bit of the sinus which is there, and when I try to this is the craniopharyngioma here. Gently trying to go around, negotiating, because this is a blind procedure as far as the posterior vasculature is concerned. So one has to be very careful when you remove the capsule of the tumor. Very gently, you remove it, and you can remove in toto. We'll move on. This is the post-op CT, because I usually do the MRI scan after about a month's time, because you don't see. This is the planum, the meningioma here. Let me tell you that once again, removing the middle terminal, raising the septal flap. This is the sella, drilling the planum. The meningiomas are higher up, and the optic nerve is below down there. So I think you need to be careful when you have to have an understanding for the planum meningiomas. And once again, you got to be very gentle and careful and piecemeal. Initially, I did not have a cavitron, but I think one can do it even without a cavitron. Because, there are not many endoscopes where you'll be able to use a cavitron through the scope, but now we have got the facility of using the cavitron. This is after I have placed, and we'll show you the reconstruction later on, post-operative. Now, this is the most important part of the surgery. After we remove the lesions, you have to reconstruct the base. Now, what is the reconstruction process? It is the inlay, outlay graft, nasoseptal flap, fat graft, and Surgicel and fibrin glue. I do not use lumbar drain anymore, because I think it gives a negative pull, and sometimes patients have got severe headaches. Now, this is the diagrammatic picture of what we do. That is, you put an inlay graft here. They can be free grafts, like from the fascia lata, or they can be, from the cranium area, you can take that. I usually take, a free graft from the fascia lata. This is the inlay, then is the outlay, then is the, the fat, and then you put the fibrin glue on top of that. And now you see how it looks like. Inlay graft. You tug into the dura. And since this is a fascia lata, you reverse it. Otherwise, it slips. Every time you try to push it in, and this is the onlay graft on top of that. You can see how big is the hole after you have done, excision of some big tumors. Fat graft, and you put fibrin glue on top of that. Very rarely I will do what I'm doing now. This is just a 14-gauge catheter, a Foley's catheter. This just keeps the graft there, and I use it for 72 hours. This is my own sort of a technique where, it stays there, and then the CSF leak is much less than what we see. And of course, after that is the nasal packing. This is about 3 years back, the results of 31 patients, CSF leak. In salar tumors, there was no leak in 95% patients, but there was a 5% patient who had a leak. In planum patients, there were 30% patients who initially had a leak. So I think with craniopharyngioma, meningiomas, planum meningiomas, for a small meningiomas, I think one must understand that there is going to be a CSF leak, and you should know it, how to reconstruct the base. Infection in 4 patients, post-operative bleed only in 1 patient, and 2 patients died in our series. The problem, bleeding, venous arterial bone cavernous sinuses, CSF leak, bony defect, incomplete removal because of the poor instruments, and recurrence and vasospasm. These are the known complications. In conclusion, ladies and gentlemen, base of the skull surgery, endoscopic transsphenoidal transnasal is promising minimally invasive approach, facilitates multidisciplinary management, effect for selective lesions of the midline cranial base. Let me emphasize here that the lesions which we remove are all less than 3 centimeters. We do not believe that, one can go for a larger lesion through the base of skull endoscopically. Avoidance of craniotomy and brain retraction, reduced neurovascular manipulation with less morbidity and better cosmetic results. I thank you all. I'll be more than happy if there are any questions anybody would like to ask. Sorry, say again. I couldn't get it. Younger patients? You mean the pediatric age group? Well, I think I do not have a much experience in pediatric age group. The youngest one, the 16, 17-year-old, because we have got a pediatric colleague who is doing that. But he's also not doing neuroendoscopic, transsphenoidal. But I think my experience is up to about 15 and above, but not less than that. And I think the youngest one was the 16-year-old lady, young girl who came with a craniopharyngioma. Is there any particular type that you're interested? Yeah, I can give you that. The youngest patient I've operated was for CSF rhinorrhea. And I do all my CSF rhinorrhea repairs through endoscope. And he was 4 years of age. I think 3.5 years of age. So I think you can use, but I have to use 2.5 millimeter endoscope. You can't put this, this endoscope, which is an adult endoscope, because that will be very traumatizing and it will even do more damage than it can do any good to the patient. Right. All right. Thank you.
Thank you, Dr. Tariq. Next, I would like to call upon Dr. Vinod Felix.
Respected close by my colleagues. I think one of the most important things about this conference is that we have a conference where we are this is a different conference. Various this is very important because many of us there are about because they come to this specialty without any orientation, without any passion. They're just being forced with their parents or they just get into the and such orientation programs are very important that so that you come to a specialty with passion. And I think what makes you a good hero in our Indian. I was supposed to talk to you on endoscopy because cavernous sinus and the transcategory. But before that, there are a lot of medical students here. I would like to orient you on what is the logic behind endoscopy. And on skull base. And the skull base, there are a lot of nerves and vessels aligned to the skull base. I think if my presentation works, I would like to show you a diagram of this. So this is a skull base, and you can see that all the cranial nerves aligned on either sides of the skull base like this. And imagine that you have a tumor here. Somewhere here you have a tumor. The approach, the conventional is to come from here or from here and remove the tumor. But then if you come from this side, you'll be closing the cranial nerves to remove the tumor. So whenever you close a nerve or a vessel, you are always at risk of injuring the cranial nerve because of the fraction you pay money when you are injuring the cranial nerve. And that is why we prefer to come through the nasal cavity, break this and remove the tumor without coming across these nerves at all. And this logic of endoscopic or the approach in the brain through the nose is not something very new. Not a rocket science at all. Even 2000 years before, there are a lot of scans of mummies which reveal that the mummies are preserved by removing the brain through the nasal cavity. If you puncture the brain through the nasal cavity, cut the brain off and inject the liquid into the brain, preserve the brain. And that's how they preserve the mummies. So with that brief introduction, there are different approaches to skull base, and the main lesions which we tackle are the pituitary tumors, the tumors which lie here in this part of the pituitary fossa, stellar fossa. You can remove pituitary tumor or like clival tumor or some tumor in this part, and these are known as the sagittal plane approach. Because in the sagittal plane, you work between the plane of two internal carotid arteries. Whereas you can come through the nasal cavity and close the carotid artery and work and remove the tumor lateral to the carotid. That's known as the coronal plane dissection. And I think you had all this anatomy and surgical video from Professor Tariq. I think I can skip all this. So coming to the sphenoid sinus. So there are maxillary sinus, frontal sinus, and between the two eyes you have the ethmoids. And between the ethmoids, around the optic nerve, you have the sphenoid sinus. This is the sphenoid sinus. And the sphenoid sinus, you have the optic nerve on either sides. And also the carotid artery will also bulge to the sphenoid sinus. And this is the stellar floor. So you come through the nasal cavity, open the sphenoid sinus. This is the stellar floor. You can remove this bone and remove the pituitary tumor. But I am going to show approaches where we go lateral to this carotid to reach what is called the Meckel's cave. The Meckel's cave and the cavernous sinus region. So that's the nasal cavity. You're seeing the inferior turbinate, middle turbinate, that's the maxillary sinus, ethmoid sinus, and the sphenoid sinus. And this is again the orientation of anatomy. This is the sphenoid sinus. I drilled the bone of the sphenoid sinus. You're seeing the paraclival carotid artery or the C5 carotid artery here. This is the cavernous or the C4 carotid artery. This is the pituitary gland. This is some dissection which Professor Ipe and I did together. You can see the entire carotid artery on the right side. This is the cavernous carotid, paraclival carotid artery. It's the foramen lacerum. And this is the horizontal petrous carotid artery. Now we are going to see a tumor in this part. Near the Meckel's cave, going to be removed through the endoscopic approach. So this 8-year-old child, he had complaints of recurrent 5th and 6th nerve palsies, which improved with steroids, but on stopping steroid, the nerve palsies came back again. So this is that lesion in the Meckel's cave region. The initial steps are similar as you saw in the previous talk. That's the inferior turbinate. We lateralize the inferior turbinate. We resect a part of the middle turbinate. And that's the sphenoid sinus opened. And that's the maxillary sinus. That's the sphenopalatine artery being cauterized. This is called the artery of epistaxis. And this is the artery which usually causes the epistaxis. If you cauterize this artery, epistaxis usually stops. So here we are doing something called the trans-pterygoid approach. We are lateralizing the pterygopalatine fossa and we are going to drill the pterygoid. You're seeing the foramen rotundum there, and that's the Vidian nerve down there. That's the Vidian nerve, foramen rotundum. You can see the maxillary nerve in the sphenoid sinus. This is foramen rotundum. And some drilling there. Once you do that, you're right on the lesion. And you have the paraclavial carotid artery coming like that, and the horizontal fetus carotid like this. So we are working above and lateral to the carotids. So that is the mesial temporal lobe. That's the area of Meckel's cave. That's after the resection, no CSF leak. So now we are going to remove a tumor in the petrous apex here, below the level of the horizontal petrous carotid artery. This is the paraclavial, this is the parapharyngeal carotid of the C7 carotid. This is the C6 or the horizontal petrous carotid. This is the paraclavial or the C5 carotids. So this is the lesion in the petrous apex. All this. That is a pterygoid bone. This is the base of the pterygoid process called the pterygoid base, and you have the Vidian nerve running in the pterygoid base. The Vidian nerve always takes you to the foramen lacerum. So you identify the Vidian nerve and drill around the Vidian nerve. That's drilling around the Vidian nerve. Identify the foramen lacerum, and then you identify the entire carotid, work below the carotid, and remove the lesion. That's the logic. In endoscopic skull-based surgery, we actually look for proximal landmarks. Landmark for a structure, for some unit, identify the carotid from proximal structure. For example, the turbinates correspond to the segments of clivus. The superior turbinate corresponds to the superior clivus, middle turbinate corresponds to mid clivus, inferior turbinate corresponds to the inferior clivus. So like that, the Vidian nerve corresponds to the foramen lacerum. So we expose the carotid artery. This is the paraclavial carotid artery. We are drilling around the carotid now. And this is the horizontal petrous carotid. This is the clivus, and this petrous apex is here. So now I am drilling the petroclival junction. And now I am pushing the carotid laterally. And then I will remove the lesion in the petrous apex. I don't like to go to further details and I'll show all these videos. I would like to just orient you about this endoscopic approach. So I think it's 10 minutes. And thank you.
So we are done with today's session. Tomorrow morning we meet at 9 again. I will request all the faculties now to go and sit in Dr. Charin's office. We will be taking you to Hotel Harrison. Okay? And you change up and freshen up, and then we come back for the cultural dinner. Okay? So, and others who wants to participate in the dinner program can willfully collect their passes from me. Okay? Thank you, everyone. Tomorrow morning we will start our session from 9. So please do come.